The first aspect to managing CAR T-cell related neurotoxicity is to understand the product that you're dealing with and what your patient's risk factors might be. We know that patients who have, for example, a high burden of disease, whether it be lymphoma or other B-cell malignancy, leukemia, they tend to be at higher risk. Certain preconditioning chemotherapies tend to predispose to more toxicity because they allow the CAR T cells to expand more. Once you understand whether your patient might be at more risk, you also have to understand, is the product you're dealing with associated with toxicity? We know that some CAR T cell therapies are associated with more and some with less. And the final aspect of it is really having a close-knit team of multidisciplinary providers working together who can help manage the patient. And that starts with meeting the patient before therapy starts, doing, for example, a baseline neurologic exam, getting a neurohistory, and then following them longitudinally immediately after the therapy and then after they leave the hospital. So that really is the mainstay. For the acute neurologic events that sometimes develop day 7 to day 14 after therapy, sometimes those can be very severe, and they can include changes in mental status called encephalopathy, seizures, depressed mental status or depressed level of consciousness. When those are severe, approaching grade 3, many practitioners will often intervene with corticosteroids, which are thought to help reverse some of that therapy, and which are not thought to affect the effectiveness of the CAR T cells. That said, there are some products where supportive care alone for the neurologic symptoms is all that's needed.